Hi there, my name is Hollings. I'm in data wrangler at NHS England, which is kind of like sometimes they're engineers, sometimes they're scientists. And today I'm going to talk about my NHS project, which is trying to improve the possible mortality benchmark measure, the SHIMI, using basically more granular diagnostic encoding. Just a disclosure, I'm employed by NHS England, and the SHIMI is also produced by NHS England. And also, there's no complaints of interest, and it isn't an official publication, it's the kind of work, or I would like to get to it. And there's plenty of those from the NHS England data science team here, folks, you can look around, please take a look. So what is the SHIMI? Well, SHIMI stands for first of all, let's back a little bit. Mortality is probably the most important outcome in hospital, I would say. And it's often used as a benchmark for hospital performance. And the summary hospital level mortality indicator, or SHIMI, is one way of measuring this. The SHIMI uses 140 different diagnostic groups and different similar conditions, and measures the mortality, the chance of dying within 30 days of leaving hospital, and then that prediction is compared against the actual number of death score. Now, the SHIMI has been criticized from some parties. I also would criticize it too, to be honest. For example, the SHIMI models themselves don't use train test slip. The justification was given to this, but to me it feels like it was being complete overfit. In addition, the data itself has extreme class imbalance between the people who lived and died, and the scoring mechanism used by SHIMI, or the available one originally, was the receiver operating curve area of the curve, which is very optimistic on imbalance data. Despite this, some models still didn't perform particularly well, in some conditions. Maybe this was because SHIMI represents a patient's diagnostic condition, all the richness of a patient condition, with a score between 1 and 3. Either they are well, ill, or very ill. Another issue I noticed were the fact that the SHIMI only looks at the first episode in a patient's spell. I noticed a trend where models that were like the lower performing model, and I need to adopt a different model. Lower performing models were much more likely to have a higher number of spells in each episode. So to me, this suggested that maybe with the current features in the SHIMI, it wasn't able to get enough information out of a single episode to make a good prediction for many conditions. Okay. And there are other problems as well, but I had a limited time, so I'll focus on these. So my approach wasn't to extract the SHIMI, it was to try to change as little as possible, but get the most from it. Try and work with the data that we've got and extract more from that. And this was because the less I changed, the more easily it would be accepted by NHS England, and the easier it would be to implement. For my analysis, I use the NHS England data access environment, also called the DAE, which is the forerunner of the current NHS England secure data environment, or SE. And then the model themselves, I use sklearn, ridge regression, and lasso regression, because the regular data techniques help prevent overfitting, and I use XGBoost because It's a powerful model which has been used very well in other mortality studies. And generally, there was some limitation on models that could do with this environment as well. For the data, I'm very lucky. NHS England, we have substantial amounts of data we can access. So I was able to use 3 years of data covering hospitals across England, covering a lot of sites and trusts. There were some exclusions though, very important when you're interpreting this. Anything COVID related excluded, except that's what the SHINI does. So I follow that methodology. That's a big exclusion, especially for the last 3 years. Non-specialist hospitals were excluded as well. I know some other exclusions, but those are the main ones. And yeah, for the first 2 years, they were used as the training and validation, with the final 3rd year being used as the hold-out certificate. And I use 5-fold stratified cross-validation to try and identify over 15 antibiotics. In my write-up and this presentation, I'm going to focus on 3 of the diagnosis groups. Just filling, I guess, SHINI splits conditions into 140. Like it's SHINI split into 140 models, each focusing on different sets of similar conditions. These were septicemia and shock, mucosal and alcohol-related liver disease. And I did actually run the models and such across the whole series of diagnostic groups essentially, but I'll focus on these now. I chose these ones for the presentation because they're quite varied in terms of how many episodes are in each one, and also the calcium balance, which is essentially mortality. Some of them have much steeper calcium balance than the others. The features I used were the same as what the SHINI uses, which you'll see there, with one major difference being that I removed the modified Charlson Index score, which SHINI uses to represent diagnostic information, and replaced it with a series of one-time encoded groups. Just for context, hospital episode, apologies, I didn't mention that I use hospital episode specific admit patient care data. For this, which was linked to ONS data. Okay, yeah. HEDPT, which is hospital episode specific admit patient care. Like 20 diagnosis columns. Each of these can contain, one of any thousand ICD-10 codes, and they can represent anything from a sore throat to a sharp attack bite. I one-time coded these into features based upon different grouping methodologies. These were the Charlson group and Ehrlich groups, which were based on the groupings used in the Charlson mortality index and the Ehrlich mortality index, respectively. And then also a much more granular, larger CTS grouping, which is based on the clinical classification software groups. To give you an idea how much more granular that was, there's like 20 plus groups in CTS alone for cancer related diagnoses, whereas Charlson group has 3 and Ehrlich has 2. So this is way more granular. And that essentially added like 268 features to the model. Okay. As I mentioned, the scoring mechanism for the SHINI was over optimistic. I'll give an example of that here. So imagine you have some different conditions. Some of them have a much lower chance of mortality. You might expect that, the same conditions, as mortality goes down, you have fewer and fewer people dying. You might expect it's more difficult to predict them. You might expect the model score, of its performance will go down. Actually, for the SHINI, we saw the opposite using its receiver operating curve score. As the number of deaths went, down, it became more difficult to less and less to train on essentially. The score kind of stayed the same, or even went up slightly. When I changed the decision recall and the curve score, you can see that as the percentage of death goes down, it can spark a larger class environment. The star actually reduces. This was because many of the original Shimmy models were pretty much just not predicting deaths and just predicting, living. And because so many people were living, and luckily you see works on both classes, it was saying, yeah, that's a pretty good model. Whereas precision recon requires both classes to be predicted well, and we really need deaths to be predicted well in these models. So yeah, that's why I changed precision recon area of the curve. Yeah. So results, what you're interested in. So just some context, I grouped together the different models, so the regression, the XGBoost into one bar each because the results are pretty much similar. And simulated Shimmy is my Python implementation of Shimmy because at the time of doing it, Shimmy was still running stack. And as we move from here using the modified Charleston index to these different group methodologies, it gets more granular, more features associated with diagnosis. And as we move, as we became more granular, the precision recall area of the curve score of the models became higher. Some cases with massive leaps up. And this wasn't just the case for these three groups here, essentially it was the case for every group that I looked at out of 142. Just looking at that and doing calibration plot, an ideal model would be following that dotted line. That's ideally calibrated. And I think arguably the blue bars there, which are the CCS group, the most granular, most close to follow that line, which suggests that with the best calibrated models, even for HIV, which is the smallest sort of amount of records, it's not going to make a great model. You can see some of those are pretty wacky, but I'd say the CTS one is probably arguably the best one, the best calibrated. And again, for the disease, I would argue that the most granular diagnostic grouping, CTS groups, gave the best calibrated model. What are the findings here and the takeaways? I would say that models with more diagnostic features, performed better, and they're better able to predict deaths on an unseen data set. This is the case for both received operating curve score, the original scoring system, and the new scoring system, which is precision recon curve score. Because if both classes are going to do well, then Rocket UC will still give a higher score anyway. And this will pretty much all three models perform similarly. XGBoost was probably more efficient, it ran much faster. But I find if they use the original model, really. Now, limitations. I think limitation is really important because every model needs to be interpreted within the remit of its limitations. Shimmy is only intended as a smoke alarm, and therefore this here will also be interpreted in that way as well. It's not the reality is simply a model. As I mentioned before, there's some pretty significant exclusions like COVID exclusions, but also you have the selection bias introduced by the fact that it only covered a 3-year period around COVID, only on hospitals in England. So, it may not apply across like the whole of, kingdom or the whole world, even like, likewise, I thought about this quite a lot with the Shimmy team, but ethnicity wasn't included, nor was deprivation. Yeah, so it's got some limitations. And likewise, despite the fact that I saw some pretty big leaps up in performance compared to the original Shimmy, some diagnostic groups still perform poorly. For example, HIV, others as well. Maybe it's just hard to conditions. It's just hard to model a relationship between hospital attendance and mortality. So my main strength in this study were that, yeah, they use more granular diagnosis encoding, for example, CCS groups, because I think it would result in better predictions of deaths. Luckily, the community in NHS England are already sort of testing this out. They're trying out the suggestion with. I suggested that they use precision recalling the score. They have taken that on board, and now they're using that in addition to the receiver operating around the score. And they have a reasoning for that, which I'm fine with. If they're using both, sure, like, but that's what we've taken on board, which is great, I feel. But I still think the shimmy does have issues. It's definitely not perfect, and it's not, you know, quite there yet, maybe. There's still a lot of unexplained variation in the models. Maybe adding other variables will help, like perhaps ethnicity or other things, although there are serious concerns about adding ethnicity and integration to the models. Yeah, so further study is definitely needed in this area. It's not like a closed book, you know, let's all pat ourselves on the back and the job well done. Yeah, we're making steps there.
Adam, we're close to time now, so
Yeah, well, that's me.
thanks. There they are.
Yeah, so yeah, if you have questions, email me. I haven't got one question. My cousins are all there. Thanks to advice of Sam Relton, Clay Jones, Helen Jackson, and Sam Hollings for all the help they gave on this. And thank you very much.